Good afternoon, everyone. Thanks for joining us in this lunch session. My name is Rafid Jaber. I'm the Medical Science Liaison at Bioscience. Bioscience is delighted to support the SOGC in this scientific educational program. Before introducing our guest speaker, I will have a couple of housekeeping notes. We will have the Q&A session at the end of the presentation. And if any questions that are coming from the virtual audience, please post it on the Q&A chat box, and we will communicate it to the speaker at the end of the session. So our guest speaker is Dr. Tim Rowe, graduated in medicine from the University of Adelaide and completed his postgraduate training at Dalhousie University, the London Hospital, and at the University of Sydney. He is an Associate Professor Emeritus in the Department of Obstetrics and Gynecology at the University of British Columbia, having been head of the Division of Reproductive Endocrinology and Infertility until 2013. From 2005 to 2016, he was Editor-in-Chief of the Journal of Obstetrics and Gynecology Canada. He edited the SOGC's clinical practice guidelines on menopause and osteoporosis in 2004, 2006, 2009, and 2014, and is a contributing author for the 2021 SOGC Canadian Menopause Society Guidelines in Menopause. In 2017, he received the SOGC's Distinguished Service Award, and in 2019, was awarded honorary membership of the Canadian Medical Association. He's a board member of the Canadian Menopause Society. So without further ado, Dr. Rowe, please, floor is yours.
Thank you, Rafid. I guess after that, it's time for me to go. Thank you all for being here. This is, I hope, a non-partisan discussion of what I think we should be telling women with PCOS, because it's a condition which is pervasive in the reproductive age group, and I think increasingly a subject for discussion and concern among women involved and women who think they may be involved. My objectives are as listed for this presentation, but essentially what I want to do is talk about the condition and then what I think we should be telling women about it. So my own meandering prejudices will come to the fore. I have a number of potential conflicts, but none of them will affect the things that I'm going to talk about. So PCOS, as I say, is a pervasive and often concerning subject for women in the reproductive age group because it carries so many connotations, and I think it starts with the name. Women who start talking about or thinking about or worrying about polycystic ovary syndrome have a number of potential concerns. The younger women will particularly be concerned about cosmetic issues. As they age, they will worry about weight. They will worry increasingly about potential fertility. But something that, again, is prevalent across all these groups is the preoccupation with having ovarian cysts, which conjures a whole lot of images in non-medical women's minds, including rupture, pain, and a number of other connotations. So you have to wonder, is the name part of the problem? And should we be thinking about calling it something else? Because let's face it, they're not cysts, they're follicles in the ovaries. And not everyone who has the diagnosis has polycystic ovaries. So again, it would be nice if we could find a better term for this, but just about every attempt to try to rename it has been pretty impossible. Somebody even suggested that we keep with the initials and call it the prevalent cardiometabolic ovary syndrome, which is much worse. And so maybe, again, this is just an aside, but maybe we should go back to thinking about Stein-Leventhal syndrome, which has the historical notes of this condition and doesn't really conjure, I think in young women particularly, doesn't conjure the concerns that the term polycystic ovary does. But again, I'm done with the ruminations. So how do we make the diagnosis? I'm reminded in the 90s, a North American luminary was making a tour of Canada to talk about polycystic ovary syndrome. And even then, we've been talking about it for a very long time. And somebody asked him, well, how do you make the diagnosis? And I still remember his answer. He said, if I say they've got it, they've got it. And I wish we could still do that, but that's obviously not a way to promote objectivity in the diagnosis. So in 1990, the NIH first formed a committee to try to bring some objectivity to making the diagnosis. And they came up with the potential 2 criteria, because remember then, ultrasound wasn't everywhere. And so the idea of polycystic ovarian morphology was not something that was readily considered in the diagnosis. But they suggested hyperandrogenism and menstrual irregularity was enough to make the diagnosis, as long as you'd ruled out other potential causes of these conditions. And then in 2003, the Rotterdam group, which sounds very Dutch, but it was actually a committee formed from ESHRI, the European Society, and ASRM, the American Society of Reproductive Medicine. So it was an international committee that suggested we should incorporate polycystic morphology in the diagnosis. And so they said, maybe come up with 2 of the 3 criteria: hyperandrogenism, menstrual irregularity, and polycystic morphology, ovarian morphology. Again, with the proviso that you've ruled out other potential causes. In 2006, the Androgen Excess PCOS Society, which is not as big a group, tried to make things simple again by saying, okay, back to 2 criteria, either with hyperandrogenism and menstrual irregularity or PCO morphology. This didn't catch on as well as the Rotterdam criteria. So for those of you who are coming up to Royal College exams, the Rotterdam criteria are going to be on the exam. So remember that. The prevalence varies. The NIH criteria reflected perhaps 5 to 8% of the reproductive age group. The Rotterdam criteria went up as high as 15% of the reproductive age population. But, well, I think, remember, you have to define these things a little better before you can say, well, this is the actual prevalence. So what is hyperandrogenism? And I think most of us use a clinical diagnosis that if a woman has consistent acne, hirsutism enough to bother her, or enough clinical hirsutism to bother her, that's considered clinical hyperandrogenism. Again, if you want a biochemical diagnosis, I use, and I know a lot of us use, just total testosterone outside the normal range for the laboratory that you use. But the problem with measuring testosterone in women is that most labs still use a radioimmunoassay, which is notoriously unreliable in the very low levels that women have. They are set to measure testosterone levels in men, which are 8 to 10 times higher. And so it's not surprising that often this measure of total testosterone will wobble quite a bit from one measure to another. If you have access to mass spectrometry, and not many of you do, but if you do have access to mass spectrometry, that's a much more reliable assay of testosterone in women. And the free androgen index takes into account the amount of actual circulating free testosterone by taking into account how much sex hormone binding globulin is around. It was thought that this would be the answer for diagnosing PCOS, but it hasn't been much of a hit. And I think we go back to saying the more reliable biochemical assay is simply total testosterone by the most accurate assay you can manage. And hyperandrogenism must be ovarian. In other words, you must rule out other potential causes before considering a diagnosis of PCOS. What's menstrual irregularity? Well, by consensus, this is now considered to be at least 2 years of cycles that are less than 21 days or more than 35 days and can be the same in one woman. What about in adolescents? Because they tend to have quite unpredictable cycles, and that is part of the problem. Making the diagnosis in adolescence is fraught with potential pitfalls because adolescents do develop a transient insulin resistance, which leads to hyperandrogenism and mimics PCOS, but it goes away. So making the diagnosis in adolescence is very tricky. Again, if you're going to make a diagnosis of menstrual irregularity, you have to rule out other potential causes before concluding PCOS is on the list. And those particularly include thyroid dysfunction and hyperprolactinemia. Polycystic morphology is a bit easier. And generally, it's taken to mean on ultrasound at least 12 or more follicles in each ovary, measuring 2 to 9 millimeters, plus or minus increased ovarian volume, that is more than 10 cc's. And I know Roger Pearson thinks the number of follicles in each ovary should be higher, but this is the most widely accepted definition of polycystic ovarian morphology. But after these criteria have been met, there's still the idea, I think a lot of us still worry that does somebody with polycystic morphology and cycle irregularity, but no hyperandrogenism, do they really have PCOS? So a 2012 NIH committee looked at this and said, okay, well, there are now 4 phenotypes of PCOS. And these are combinations of the criteria that will enable us to say, yes, you do have PCOS, but you've got the good kind, or you've got the bad kind, or you're going to have to worry about this, or you not have to worry about that. And this hasn't finished because an international review set of authors in 2016 narrowed these phenotypes down to 3. And again, we're getting caught in semantics here, but if somebody has hyperandrogenism, cycle irregularity, and PCO morphology, they have the classic PCOS or phenotype A, according to the NIH criteria. This group got rid of phenotype B and said there is ovulatory PCOS, that is women with hyperandrogenism and PCO morphology, but regular cycles. And then down the bottom is phenotype D, which is the non-hyperandrogenic type who have just PCO morphology and oligoovulation. And old school types like me say that's not really PCOS, but according to these criteria, it is. Okay, whatever phenotype women have, the reassuring thing we can tell them is that there are lots of, not lots, but there are several large cohort studies that have shown that the symptoms improve over time. And this is one from a European group showing that both hyperandrogenism and cycle abnormalities improved as a woman aged from her adolescence into more than 30. PCO morphology doesn't change very much, but the other things do. And there's been a more recent Dutch study which said the same thing, that if women are concerned about their symptoms, they do gradually improve over time. Okay, well, we know about the effects of PCOS on long-term health, but we do have to take these into account when we talk about management. And the clinical considerations that we have to consider in women with a diagnosis of PCOS, the cycle irregularity in and of itself is concerning for a lot of women, but in the long term, we have to remember it does increase the risk of endometrial proliferation, abnormal bleeding, endometrial hyperplasia, and endometrial cancer. So in terms of avoiding life-threatening risk, this is perhaps at the top of the list. The concerns about hyperandrogenism and the clinical consequences, again, are ethnicity dependent. And living in Vancouver, it's interesting to see the difference between East Asian women who virtually never have any cosmetic concerns and South Asian women who have concerns to burn. So if you don't use a strategy for assessing hirsutism, and I think none of us really do, although we should use the Ferryman-Galway rating score. Women, for example, who are from East Asia, any Ferryman-Galway score over 2 is considered abnormal, whereas in Mediterranean women and East Asian women, it's got to be quite a lot higher, perhaps over 8. But the effect of this, I think, can't be discounted, that this is a real blow to self-esteem for women who do have these cosmetic issues. And they will usually, before they see you, have resorted to some form of local therapy, but particularly for hirsutism, these can be expensive, time-consuming, and not terribly effective. Infertility is what is a major concern for women as they approach their 30s with PCOS, most commonly due to variations in ovulation frequency, but because of the androgenic microenvironment of the ovary, there's also an effect on oocyte quality. And if they do get pregnant, remember, they may have multiple complications during pregnancy. So fertility, a major issue and a major concern here. But for our internist colleagues, they worry most about cardiometabolic risks. And there is an increased potential for women with PCOS to have insulin resistance, and I'm coming to that in a minute, increased potential for weight gain, development of diabetic tendencies and diabetes itself, and increased prevalence of various metabolic abnormalities, including metabolic syndrome and clinical atherosclerosis. So again, this is a pretty serious condition if you look at those clinical considerations. There have been numerous potential mechanisms proposed for why women develop PCOS. But in the next few minutes, I'm just going to talk about 2 of them. The abnormal GnRH pulsation, which is what leads to the cycle irregularity and the hyperandrogenism, and then insulin resistance, which leads to all the metabolic complications of women with PCOS. So abnormal GnRH pulsatility has been recognized for a long time, but it's puzzling to know why women develop this. And the theories have ranged from a genetic predisposition as the cycling center matures, an effect of androgens or lack of progesterone feedback in adolescents or peripubertal young women developing a normal GnRH pulse frequency. For a long time, there was a dopamine deficiency theory that suggested that the neurotransmitters governing GnRH pulsatility are disordered. And because this GnRH pulsatility resembles what we see in postmenopausal women, it was only time before the involvement of the KINDY neurons, that is kisspeptin, neurokinin B, and dynorphin, were invoked as potentially involved in this increased GnRH pulsatility. And you may be aware that neurokinin B has been isolated as probably the key neurotransmitter in triggering hot flashes in menopausal women. And the neurokinin 3 antagonists, that is the receptor for neurokinin B antagonists, are before Health Canada at the moment seeking approval to be marketed as a treatment for hot flashes. They're very effective without any of the hormonal effects of hormone therapy. So it was only a matter of time before these things were followed up. And the neurokinin B theory is predominant at the moment, but still we do not know why GnRH pulsatility is increased in women with PCOS. And even the man who knows everything doesn't know why this is. So, as I said, it was a matter of time before randomized controlled trials of one of these neurokinin 3 receptor antagonists was tried in women with PCOS. And the first, this is the one before Health Canada at the moment, fezolinetant. Don't you wish they had shorter names? Fezolinetant has been used as treatment for women with polycystic ovary syndrome with these quite marked effects. This shows at the top a dose-related effect on reducing circulating total testosterone, and at the bottom, as you would expect, a reduction in LH, reducing GnRH pulsatility. So you're going to hear more about the use of neurokinin 3 antagonists in the management of women with PCOS. For now, all we have to reduce these pulses is a combined oral contraceptive. That's what we use. And it works as well, but carries its own baggage. So moving on to the insulin resistance question, do all women with PCOS have insulin resistance? The answer is no, but a substantial portion do, and particularly if they are obese, the classical women with PCOS and obesity and cycle irregularity and hyperandrogenism. You can see on the left the insulin response to a glucose load with very small confidence intervals, in contrast, increasing in women with PCOS, in contrast to women with elevated androgen levels or normal cycling and normal androgen levels. And on the right, you can see lean women having the same increase in insulin response to a glucose load, but the wider confidence intervals say less of them across the board are affected. But again, it's not the hyperandrogenism driving this, it's something about the PCOS diagnosis itself. So women do have increased insulin responses, and women with PCOS who have insulin resistance appear to have a disorder of insulin action, which arises from decreased insulin receptor signaling. And the classical PCOS women are those who are at highest risk for having insulin resistance. We do know that PCOS as a whole is associated with an increased risk of type 2 diabetes. If we identify women in the PCOS subgroup who have insulin resistance, they're at risk for a whole number of metabolic complications, including metabolic syndrome, hypertension and dyslipidemia, endothelial dysfunction, non-alcoholic fatty liver, PIH, gestational diabetes. So a whole lot of reasons to be wary of insulin resistance in these women. Increased insulin is bad in terms of hyperandrogenism too, because insulin not only increases the exaggerated pulsatility of GnRH release, leading to more LH, more stimulation of the theca cells and increased thecal androgen production, but it also facilitates adrenal androgen production, and it lowers SHBG levels, so more free androgen, more free testosterone available. So high levels of insulin are really bad news in terms of PCOS. And how do we identify whether someone has insulin resistance, apart from looking at the back of their neck? It's best done by the homeostatic model assessment calculator. And if you haven't got this, many of us in Vancouver have got this on our desktop, computer desktop, because it comes up as a little, here's the download site. You can download it easily. It has a version for Mac, it has a version for PC, and you simply have to send women for fasting assays of glucose and insulin and put those numbers into this calculator, and it will give you the homeostatic model assessment insulin resistance index. And you want to keep that number at 2 or less. So how do we keep women with insulin resistance and an HOMA-IR level above 2 where they should be? Traditionally, we've used metformin in daily doses, generally around 1,000 milligrams a day. Metformin's a very good drug, but it does have its downside. It's a prescription drug. It does have potential for ketoacidosis and sometimes nausea and diarrhea. The thiazolidine diones, another family of drugs that do this very well. Troglitazone was masterful at reducing insulin resistance until it also caused liver toxicity and had to be taken off the market. Again, this is getting outside my wheelhouse and probably outside your comfort level too. So we come back to the better option in my mind, which is myo-inositol. And the dose that's been used in trials of this for controlling insulin resistance, 2 grams of powder twice daily or a gel cap of 600 milligrams twice daily, usually combined with folic acid for a number of reasons. It's available on Amazon. The gel cap will be coming later this year as an over-the-counter non-prescription agent. But I'm talking about myo-inositol, and you may say, what the heck is myo-inositol? The inositols are a naturally occurring group of chemical compounds found in plants and animal tissues that appear to be second messages for insulin's intracellular activity. And myo-inositol, there are 9, I think, of them that are identified. Myo-inositol is just the most prevalent one of this family. And it's led to the proposal, which carries some weight, that a fair amount of PCOS may be a result of myo-inositol deficiency in target cells, leading to reduced potential for insulin activity and consequent increases in insulin activity. Myo-inositol has been referred to as vitamin B8, but vitamins are vital amines, and you have to have a significant abnormality if it's deficient in the diet, and that's yet to be recorded. So vitamin B8 may be a stretch. But myo-inositol treatment in women with PCOS has been quite remarkable in multiple studies, that it does have the potential, not in everybody, but in women with increased insulin sensitivity, the potential, increased resistance, the potential to change that so that there's increased insulin sensitivity and a reduction in insulin levels, which leads to reductions in androgen production from theca cells and possibly induction of regular ovulation, menstrual cycling, improved oocyte quality, and in women going through fertility treatment, a reduction in the dose of FSH required for follicular stimulation. Okay, so this is from a German study. A lot of the studies are not controlled, so we have to take some of the statements with a grain of salt, but this is the measure of response that has been reported, that after 3 months of treatment, 3,600 women with PCOS, Rotterdam PCOS, treated with myo-inositol standard dose and folic acid, showed a reduction of over 50% in total testosterone and an increase in the number of ovulatory cycles. So it's potentially very effective in women with PCOS. So I'm going to finish up now again with just my meandering prejudices about this, but forgive me because I'm at the prejudicial stage of my life now. What should we be telling them? Well, the first thing is they may not have PCOS, because there is an alarming tendency, I think it's reducing now, but an alarming tendency of young women who have pelvic ultrasounds in whom polycystic morphology is identified to be told you got PCOS. It's not. They don't have it. So they may not have PCOS at all. If they do, again, remembering those prospective cohort studies, symptoms do tend to modify and become less significant over time. And the best strategies still to begin with are lifestyle strategies. I'm not going to go into these in detail. I'm just going to mention a study that was done in South Australia. Woohoo! South Australia's Department of Health funded a prospective study of obese women, 60% of whom had PCOS, to have them go through a program of diet and exercise to see what happened to markers of morbidity and their potential fertility. Now, this was a pilot study, so there were 20 women in this study to start with, all overweight and all anovulatory. And after 6 months, the ones who stayed in it, 13 women stayed in it, 7 dropped out. But of the 13 women who stayed in the program, they lost a mean of 6 kilograms with this program, which included counseling about diet and an exercise program. They even bought their running shoes for them. This was a very comprehensive program. 12 of the 13 resumed ovulation, 11 of the 13 got pregnant without any further intervention. They did the calculation to see how much this would cost applied across the board in the whole state of South Australia. The cost of the program for those 20 women was the same as 1 IVF cycle. So, of course, they canceled the program, which was stupid. Anyway, it does show that it's possible to restore normal ovulation in obese women with diet and exercise. And I think the most important things that I'm going to emphasize here are the need for physician support and physician encouragement, because believe me, it goes so far if you're buying into somebody's program to lose weight. Structured exercise, again, we don't really have the ability to go out and run with these people, but it is important to maintain your support for them. So lifestyle issues, okay. Again, I would suggest strongly that you use that HOMA2 calculator to see if the women with PCOS do have insulin resistance. And if they do, then you can offer them the use of metformin if they want, or myo-inositol. And in Vancouver, the home of crunchy granola, most women will go for the natural option. And it does seem to work really more than I expected. Women who are craving pregnancy now will find that ovulation induction with letrozole is usually effective. Women who don't want to get pregnant and who want to control their symptoms, use of a combined oral contraceptive, and it probably doesn't matter which one, will usually restore regular cycling and minimize the risk of endometrial hyperplasia. If they use a combined oral contraceptive, their acne and hirsutism generally will improve. And again, it doesn't really matter which one you use, although arguably cyproterone-containing oral contraceptives are the top of the poll. But the problem with using combined oral contraceptives, and women will tell you this, is that it's not going to control their weight. And if they have insulin resistance, it's not going to make things better. Women who have menstrual disturbance but don't want to use a combined oral contraceptive and don't really know what they want to do going forward must have their risk of endometrial hyperplasia minimized by cyclical use of a progestogen. And if they want non-hormonal control of acne and hirsutism, spironolactone is effective at reducing androgen activity in the skin. In fact, it's become a favorite of dermatologists, which is interesting. It's taken its time, but it is an effective agent. Use of a progestin-releasing IUD will protect against endometrial hyperplasia, abnormal uterine bleeding, and unplanned pregnancy, but it does nothing for the cosmetic effects of PCOS and may make them worse. So that has to be taken into account as well. And as I said, keep your eye out for the neurokinin 3 antagonists, because I think even though they will be approved by Health Canada for management of menopausal hot flashes, there's going to be a pretty rapid uptake for control of women with PCOS and abnormal cycling as well. For those of you who are interested, this was published, I think, this week in Fertility and Sterility. It's a long read, but if you're a history buff, you'll find it interesting. If you're not a history buff, don't read it. It's very long. Okay, so again, 150 years is a long time, and we're still not there. But this, interestingly, this historical review has looked at how we started with anatomical bases for research, then we moved to the metabolic bases for research. We're probably now into the molecular stage, and sooner or later we will get an answer for PCOS, but it is going to take some time and we have to take the long view. So thank you very much for your attention and for listening to my prejudice.
Thank you very much, Dr. Rowe, for this interesting presentation. Now we open the floor for questions.
So I think you might have mentioned this, but I might have missed it, but I have a lot of South Asian women in my practice. And if they have oligomenorrhea, they have PCOS by definition. And so you mentioned that there was maybe some different criteria for hyperandrogenism in like ethnically based, or?
Only if you're going to be truly objective about it. Because yes, the South Asian women, Mediterranean women do have intrinsic hirsutism. It's familial. It may be related to 5-alpha reductase activity in the skin. We don't know, but it's an observation that appears to be familial and ethnically related. I think we just have to say if they have abnormal hair growth that requires cosmetic attention, then they have hyperandrogenism by definition. It's the East Asian women who are the problem, because they can have horrific levels of testosterone with nothing showing in the skin, because the population of follicles is so thin in those women. So if you are, again, if you're using Ferryman Galway, that doesn't apply. I hope you know what I'm talking about, the scoring system for hirsutism. It doesn't really take ethnic differences into account. So again, it's not very good. And we come back to my old friend saying, if I say they've got it, they've got it. There is a potential, I haven't mentioned things that you can use. Most women will be using trimming, bleaching, plucking for hirsutism, but laser is popular among younger women. I don't think it works very well. Electrolysis, it's very difficult to find a technician now who knows how to do that. And I don't know if you have any experience with Vanaquer and eflornithine. Anybody? It doesn't really work. It was on the shelf of the manufacturer as a treatment for sleeping sickness. And I think they realized that they weren't going to make any money out of a sleeping sickness treatment. So it was found to interfere when applied topically with the way hair follicles form hair. But again, it requires a lot of labor. It requires a 2-hour at least application twice daily to the skin, then it has to be wiped off. And again, I'm with you. I have very few people who have found it very helpful, but it is on the list of prescription agents.
Thank you. Maybe, sorry, if you get the microphone so the people, because there are virtual attendees, they can hear this one.
So the question is, sounds like this. lately I have a burden of patients with PCOS, very young, obese, who are on 2, 3 at least antipsychotic medications. And they are not able to take combined contraceptive, or if they take, they say they affect their mind, they don't feel like themselves, so they have adverse psychiatric effects, psychological effects from them. But they also want to have regular menstrual cycles because they think that is healthy. I think that's, social media teaching. So how we deal with this kind of patients? What is your insight on this?
Yes, I know what you mean. These people are a particular concern because it's the antipsychotics and the anti-epileptic agents that appear to have a mechanism by which they can promote the development of PCOS. It's in the majority of cases, it's not possible to have them change their medication, although that's an obvious place to start. If you can find something that is less clearly identified with induction of PCOS morbidity. If not, then you are stuck with the same concerns that you worry about: the metabolic consequences, the uterine consequences, and the cosmetic consequences, and you can deal with them in the same way. Oral contraception, I do look for insulin resistance in these women and see if you can get them to add another medication, but they are a difficult group to deal with. I appreciate that they're already on a lot of medication and they have difficulties with adherence to medication protocols. So I sympathize. I don't have a quick answer for that. Maybe the new uricinin 3 antagonists will be the answer.
There's a question from the chat here. Is weight gain a cause and an effect of PCOS? I see patients who blame PCOS for their obesity, whereas I was taught it is more a cause of the hormonal balance.
Well, again, we're talking chicken and egg. I think the undeniable fact is that if women develop insulin resistance and hyperinsulinemia, they will have a tendency to weight gain, plus all the metabolic consequences, but they will find it much more difficult to lose weight, unless you can increase insulin sensitivity in those women. And again, I don't want to sound like a salesman, but I have found that myo-inositol goes very well with these obese women who are having great difficulty losing weight. But again, you have to demonstrate insulin resistance in them. And if they are simply overweight because of a genetic predisposition or something else, then that's not going to respond well to any form of treatment. Again, the physician's central role in lifestyle modification can't be underestimated. And the trouble is, it's very time consuming and individual focused. So it does take time, but if you demonstrate in obese women that they do have insulin resistance, then you've got another approach that will help them get their weight down. And if their insulin levels come down, again, we don't know if it's the obesity or the insulin levels, then you will have an improvement in the other variables as well.
Question.
Hi, I'm just wondering about the side effects of myo-inositol
Right.
and why it's over the counter, I guess.
I think it's over the counter because it doesn't have any side effects. Again, no, well, I've had women use this for several years now and have never yet had anybody who said there's a problem with, induction of something or other. I always say it's got an unfair comparison with metformin because metformin does have the GI effects that no women will like. If they're lucky, they don't get them. But no, haven't heard any myo-inositol side effects? I mean, I don't know if you can talk about why it's over the counter.
Well, I think it's, I mean, talking about the particular dose that is used in women with PCOS, I mean, as you mentioned, there are no side effects, but they try to see what is the level of tolerance. And the current one with the powder, if we talk about the powder, is up to 4. So they tested up to 18 grams per day, and they found anything that is 8 and above. There is a review on that one. They started to have some GI upset and some side effects. That is, I mean, so far what was reported.
Yes.
Thank you for an excellent talk. If I may just make a plug, you're talking about hirsutism. Well, the SOGC guideline on hirsutism has just been rewritten and is working its way through, but you'll find a lot of the answers to the questions that were posed. We have tried in that document to use the data that's available so that by ethnicities, because if you're using a Pheromone Galway score, if you are from East Asian, anything above 3 would be regarded FGS of 3. If you are from Southeast Asian, probably 11, and Caucasian somewhere in that 8 range. So we've tried to make that clearer, but it still remains murky. The big omission in that document is the trans population. We do realize that that's an omission, and we'll deal with that probably in 5 years' time when we rewrite it again. But people will hopefully find it a lot more useful than the 2016 version. Not that this is a shameless plug, but it should be a good read rather than insomnia treatment.
That's a very good plug. But just show of hands, how many of you are using Pheromone Galway even occasionally? A couple, okay. Yeah, until something better comes along, we're stuck with it, but at least we know what it is. Okay.
And there is a question from the virtual group here. Is there any evidence for a benefit of myo-inositol for women who either have or are at risk of endometrial hyperplasia, whether or not PCOS was ever identified?
To my knowledge, no. I would presume that if someone is at significant risk of endometrial hyperplasia, the correct response is appropriate doses of progestogen and continued monitoring surveillance. So no, as far as I'm concerned, there isn't any link between myo-inositol therapy and endometrial disease. Okay.
Are there any other questions? The floor here. Maybe I'll take the liberty of asking the last question. I'm back to the diagnosis. I wanted to ask you about it. So what will be the key messages and recommendation when it comes to diagnosis of PCOS out of all the different criteria that are there?
Well, I think it's fairly straightforward that if it's interesting, the presentation often is somebody who has had one of the criteria and says, have I got PCOS? Often it's hirsutism or acne, and they have heard from their friends that you've probably got PCOS. So I always will ask, again, it has this very long and boring history, but what about their cycle rhythm? And what about the cosmetic hyperandrogenism? Is it in fact documentable objectively? And then if it's appropriate, we will arrange for biochemical assessment, an androgen profile to rule out adrenal hyperandrogenism. So I know I'm overkilling, but I always assay testosterone, total testosterone, androstenedione, DHEAS, and 17-hydroxyprogesterone, just to make sure they're not an adult onset adrenal hyperplasia. And then, if appropriate, we'll use a pelvic ultrasound to identify ovarian morphology. And again, if they have any of the hallmarks of insulin resistance, we'll do fasting glucose and fasting insulin. It's more likely we'll do that in women who are overweight or obese, if they have normal body mass and no family history of diabetes, that may be deferred. But the ones who are obese or overweight, I'll always look for insulin resistance. So that's quite a workup. There's quite a lot of investigation. But I think for women who are significantly concerned about the diagnosis, it's as well to be able to look them in the eye and say definitely yes or definitely no.
Thank you very much. And would like to thank you, Dr. Rowe, for this interesting presentation and for all the audience for attending this session. Looking forward for future one. Thank you very much.